So the next speaker is Luisa Escobar-Hoyos from the United States, and she's been selected to present here on a topic that certainly triggers the imagination and reflects the advancement in our capacity to make diagnosis. She will speak about how do we have to classify the sort of old friends, CIN 1, 2, and 3, now that we have much better and more accurate technologies to identify stages.
Thank you very much for that nice introduction. We don't have any competent interests. So the talk that I'm going to present today, it's entitled Molecular Classification of Cervical Intraepithelial Lesions and Carcinoma, how we went from the proteomic discovery to the immunohistochemical validation. This study was done in Stony Brook University in New York. So this cartoon represents the histopathogenesis of cervical cancer following the linear model. As we all know, cervical cancer, represented here by SCC, squamous cell carcinoma of the cervix, is preceded by two premalignant lesions. The first one being the low grade, which is low-grade squamous intraepithelial lesion, or LCIL, and the high-grade lesion, which is the LCIL. When LCIL patients are not treated, there is a high rate that they will clear this infection, around 90% of the patients. However, if left untreated, the high CIL, there's a high percent of patients that would progress to cervical cancer, referring that these are high-risk patients. And it's also believed that 10% of LCIL patients will progress to the high CIL stage. Currently, there is a high variability in the classification of the premalignant lesions. The best characterized biomarkers that we have right now are the high-risk HPV testing and the P16 stain. However, as it has been stated in several of the talks here, this high-risk HPV testing has low specificity. In addition, it's limited by the high rate of clearance of the LCIL patients. P16, which is the other biomarker surrogated to HPV, is not stage-specific, and in addition, it doesn't have any prognostic value. So we conducted a screening project to try to look for stage-specific biomarkers that can aid in the classification and diagnosis of the premalignant lesions. So our hypothesis was that there are stage-specific molecular signatures that are specific for the stages and that they might reflect cervical cancer progression. In order to test this hypothesis, we wanted to first identify stage-specific biomarkers, and for this we used a proteomic analysis. Secondly, we wanted to quantitatively and qualitatively validate the biomarkers that we identified by the proteomic analysis and validate them through immunohistochemical staining in histology specimens and tissues. So in order to identify the stage-specific biomarkers, we conducted a label-free shotgun proteomic analysis. So what we did, we laser captured normal cervical squamous epithelium, LCIL, high CIL, and cervical cancer, and we subjected these samples to protein isolation, digestion, purification, and then we separated them by two-dimensional liquid chromatography, and we submitted them to mass spectrometry. From the spectral count, which is the relative quantification, we filtrated this data according to a 1% false discovery rate. And the proteins that we selected to validate with the immunohistochemical analysis were those proteins that at least had a twofold difference between stages. So in order to validate the proteins that we had identified by proteomic analysis, we did a quantitative immunohistochemical analysis. First, we constructed tissue microarrays of 25 cases per diagnostic category, with 3 cores each. For this, we use formalin-fixed, paraffin-embedded tissues. In order to perform the immunohistochemical analysis, we use an indirect method using primary antibodies with biotinylated secondary antibody and using the avidin complex with the horseradish to oxidize the DAB. We used two methods to quantify the DAB precipitation. The first one was the NIH digital software image analysis, which gives a relative quantification of the DAB stain. On the other hand, we use another method, which is the PathSQ, which is a semi-quantitative scoring system for the DAB staining. And basically what it does, a pathologist divides the intensity of the stain being 0 negative, 1 a light DAB stain, and 2 a dark DAB stain. And the pathologist calculates the percentage of cells in each one of these intensity categories. We perform several statistical analyses, first to determine if there were differences between the stages, to determine the specificity and sensitivity of each one of the biomarkers that we were validating, and we also perform Kaplan-Meier tests to see if any of these biomarkers will tell us about the prognosis. So from the proteomic analysis, we were able to resolve 100,000 spectral count, and we identified 2,014 proteins that, according to gene ontology, they were localized to several sublocalizations of the cells, and here represented on this pie chart. Today, I'm going to tell you the story behind two proteomics that are found in the cytoskeleton, and they were differentially expressed in each one of the different categories. So in this table, what we have is the proteins, and each one of the categories with the respective spectral count for each one of these categories. And according to what these numbers were telling us, what we predicted they might work as. So first we have keratin 4, and as you can see, the values decrease with progression to cervical cancer. So we predicted that this was going to be a progression marker. From the same family of the keratins, we selected keratin 17, which according to the relative quantification, we predicted to be an LCIL, HiCIL, and a cancer biomarker. We were also able to identify P16, which is the gold standard marker from our mass spectrometry analysis. So here, you have representative photos from the immunohistochemical stain performed, and these are representative photos from each one of the categories where we have keratin 4 staining. So as you can see, and as predicted by the proteomic analysis, we see a decrease in the expression of keratin 4 from normal to cervical cancer. In addition, I have put the photos for P16, which basically has an inverse expression according to keratin 4. So here in this box plot, we have the quantification by both scoring methods. The light gray, it's according to ImageJ scoring system, and the dark gray according to the pathology SQ. So what we were able to identify is that the expression of keratin 4 was statistically decreased in HiCIL and almost lost in SCC by both scoring systems. And this decrease in the expression of keratin 4 was lower in HiCIL and SCC versus the normal and benign lesion. Then we perform the ROC curve analysis. And what we have here is the area under the curve was at 93%. And keratin 4 gave us a sensitivity of 96% and a specificity of 82%, comparing HiCIL and SCC versus normal and LCIL. Here, now we have representative photos of keratin 17 stain for each one of our diagnostic categories. And what you can see, and it's pretty obvious, there is a high overexpression of keratin 17 that is specific for HiCIL and SCC. Again, we have the box plots for both scoring systems, and what we were able to determine it was that this overexpression was statistically significantly different in high seal and SCC versus normal and LCL. And then from the ROC curve analysis, keratin 17 was giving us an area under the curve of 90, I don't see it well, okay, 99, and a sensitivity of 98%, and a specificity of 97% with a misclassification rate of only 3%. So this was encouraging to us. So one of the most important aspects when you're trying to identify and validate a new biomarker is to identify those potential factors that could modulate the expression of the protein, which we refer as confounding factors. There has been, according to the literature, we know that sometimes the patient age or the time of the tissue storage can influence the expression or the staining of a protein on a tissue. On the other hand, we went back to the literature to see what increases the expression of keratin 17. And what we found is that conditions such as inflammation, injury and wound healing, viral infection, and cancer can trigger the expression of this protein. So we set up ourselves to test if keratin 17 expression was modulated by the patient's age and the tissue storage. In these histograms, what we have is the quantification of keratin 17 by image J scoring system. And we have the patient's age and the time when the surgery was done that refers back to for how long the tissue has been stored. And what we were able to determine with the Pearson correlation is that keratin 17 expression did not depend on the patient's age and did not depend on the tissue storage time. Then we went and tested the conditions that have been reported to trigger keratin 17 expression. So for this, we selected cases of normal cervical mucosa, cervicitis, which is implying an acute and chronic inflammation in the cervix, biopsy site changes, which is a category for pathologists of a wound healing process going on. Two types of viral infections can occur in the cervix. The first one is the HPV, and then the other one is the herpes simplex virus. LCL, which is the productive HPV infection. And when we compare the expression of keratin 17 in high seal and SCC versus the other benign or premalignant LCL or other infection with herpes, we determined that the expression of keratin 17 was statistically significantly higher in high seal and SCC versus the other conditions. We also wanted to know if keratin 17 expression was dependent on the HPV type. So what we did, we genotyped the high-risk HPVs for our patients. And here in this pie chart, you have the percentages from each one of the high-risk HPVs. And when we compare keratin 17 expression between the different patients that have different types of HPV, we didn't find any statistical significant difference in the expression of keratin 17 within these different types of HPV infection. So far, from what I have showed you, a biomarker can have a different impact. It can tell you about the etiology of the disease, suggesting a risk factor. It can tell you about the detection that can go back to the diagnosis and the screening. And it can also detect the disease. So far from our preliminary data, what keratin 17 was telling us is that could help us in the diagnosis specifically of the high-grade premalignant lesion, and in addition of cervical cancer. So then we asked ourselves, what is it telling us about prognosis? So from our screening study, we were using 25 patients for each category. And what we did for this prognosis analysis, we increased our sample size of cervical cancer patients to 80. So prognosis is a relative estimation of the outcome of the patient, what has been diagnosed. In our case, it would be cervical cancer. And we know that prognosis can be different among stages of a cancer. So what we did, we took our 80 patients of cervical cancer and we divided them by stages. Here you have them represented in these cartoons. And when we compared the different stages, if they had different expression of keratin 17, we were unable to test if there was a statistical significantly difference among the stages. In addition, prognosis can be related to the grade of the tumor. So when pathologists receive a sample, they not only determine that it's cervical cancer, they determine the stage, and they can determine also the grade. For those ones who don't know what is the grade, we can say it's a level of dedifferentiation of the cells. And again, when we compare both grades, we didn't find any statistical significant difference. And also, we wanted to divide our patients by if they were lymph node positive or lymph node negative, meaning that, the cancer had spread to the lymph nodes, and we didn't find any statistical significant difference. So then we went ahead and divided our patients, not because of the stage, not because of the grade, not because of the lymph node status, but we divided them according to the expression of keratin 17. We divided our patients if they had a high expression of keratin 17 or a low expression of keratin 17, according to the 70th percentile of the image J scoring. And when we did the Kaplan-Meier curve, we were able to correlate the patients that had a high expression of keratin 17 correlated with a poor prognosis. And when we compared both survival curves by log-rank tests, we were able to determine that these two curves were statistically significantly different. Okay, I'm almost done. Okay, so we went to the literature and we were encouraged to find what's known about keratin 17 in cervical cancer progression, and we were able to find 4 studies. And here what you have is the percentage of positive cases per category, the scoring system, and the reference. What is common to all these studies is that they reported an increase of the expression of keratin 17 in cervical cancer. However, the positive cases for high seal category were not the same among all the studies. It could be attributed to the sample size, and it could also be attributed to the scoring system that they use. Then we asked ourselves the question, what is known about keratin 17 among different cancers? So we did an in silico analysis using the Oncomine database. And here what we have is intensity values of keratin 17 on the y-axis between normal and cancer in different types of organs or tissues. And what the in silico analysis told us is that at least there is a 32-fold increase in the expression of keratin 17 on this log2 scale. And the only cancer that had this amount of expression of keratin 17 was bladder. So to conclude, keratin 4 decreases with neoplastic transformation. We had a sensitivity of 96 and a specificity of 82 with keratin 4. Both the specificity and the sensitivity tests for both types of keratins were independent of the type of HPV, and also independent of any test of high-risk HPV or P16 stain. Keratin 17 gave us a sensitivity of 98 and a specificity of 97. And the high expression of keratin 17 is independent. It's a prognostic marker independent of grade, stage, or lymph node status. So far, we can say, and for future studies and what we are already conducting, is that keratin so far seems to be a potential marker for the diagnosis and prognosis, specifically within the cervical cancer patients. What we're trying to do now is to increase our sample size even higher. And we also want to include in the cervical cancer patients the adenocarcinomas cases. And also what we're now doing is trying to validate and to see if keratin 17 could be useful for screening. So we're going to run this marker in cytologies also to see the predictive value for high-risk, high-grade lesions in undetermined categories like ASCAS or ASC-H. And with that, I will be more than glad to take any question. Thank you. I would like to thank my group. I would like to thank our collaborators, the Proteomic Score and the Biostatistical Consulting Consulting Corps at Stony Brook University. My funding, I am a Latin American coming from Colombia, the travel awards that I got, and thank you very much for all your attention.